So welcome everyone to Equity in Behavioral Health webinar series. My name is Mihei Zhang, and I work as a Community Advocacy Director at California Pan-Ethnic Health Network, and I will be your facilitator today. Communities of color and LGBTQ plus communities have historically been unserved or inappropriately served by California's behavioral health system. We hope that through these webinars, you can learn more about the mechanics of our mental health system, substance use treatment and prevention, and strategies to reduce disparities, and give you some ideas and opportunities on how to get involved in policy advocacy so that California's public mental health systems can truly serve all people. Okay, next slide. So today we have three great speakers with us that are going to share with you their experiences from decades and decades of working in behavioral health fields. And so we're really excited to have that.
The early 90s, we have also been a court-mandated provider because SUD in general intersects with the criminal justice system greatly. And most Asian Pacific Islander SUD participants rarely walk into treatment, but many get caught and are mandated treatment. About 3 years ago, we became a federally qualified health center lookalike, and so that has expanded our ability to do SUD services. And we also have been a drug Medi-Cal state provider, and drug Medi-Cal has gone. It's being administered by our county, and that started in June of this year. And we provide outpatient and intensive outpatient programs to Asian populations as a drug Medi-Cal provider here, this county. So, I would just like to share with you what I see as an assessment of the present situation and how it relates to the community I serve. Orange County is most people think of this as a very white bedroom community and county, but it's rapidly changing. We saw that in the last election. And at present, Orange County is about 22% Asian, and it's become a majority county, which means that it's an exciting time to do SUD work here in this county. So if we can go on to the next slide. I am just one provider, but this is my assessment of the present SUD situation for ethnic service providers. I am going to focus only on SUD funding, SUD specific funding, and not the broader behavioral health funding. It is possible to do some treatment under behavioral health, the broader behavioral health category, but the reality is, or MHSA, Mental Health Service Act dollars, but the reality is right now, most of the funding in my eyes is coming through three funding silos. And I want to start out by sharing a quote that I found in a substance use almanac. And this quote you can see on my PowerPoint basically summarizes that it's still, substance use disorder is still clouded by stigma, and it's being, it's in the process of being understood as a chronic illness. And hence the entire healthcare system is now only beginning to identify it and treat it and pay for it that way. So what that means is I think our SUD system is in transition, and ethnic service providers or providers who work with communities of color have to adapt to a rapidly changing system. So at present, the largest source of funding for SUD treatment is coming through drug Medi-Cal, and this is very recent, the changes that have happened. Drug Medi-Cal usually was administered by the state, But in 2015, an 1115 Medicaid waiver changed this and implemented a 5-year pilot project here in the state, which really revamped the alcohol and drug treatment system. And what it did was it really follows now ASAM criteria, and there is a continuum of care, and it really is revolutionary. But its implementation has been a little creaky. And so for my county in Orange County, we were, I believe, in the second wave of counties implementing this, and it has just started. It's 5 months into starting, and it still is. It has lots of kinks, and it's a little crazy in its implementation process. But this is the main route to alcohol and drug treatment now in our county. Alternatively, or concurrently, I believe Drug Medi-Cal or the state DHCS is I don't know if it's funded, but they are implementing a hub and spoke medication assisted treatment program, and so we will. It has not. Orange County is not that involved in this process, and we haven't seen much movement, but we do know it exists. So, under the big drug Medi-Cal umbrella, most of the substance use disorder treatment is being provided. With that said, the traditional county programs, the county programs provided through federal SAPD funds, the Substance Use Abuse Prevention Treatment Block Grant, as well as those funded programs still exist. And those funded programs now, with the advent of Drug Medi-Cal, are primarily used in our county for the uninsured. And then finally, the biggest change was probably in 2014. And 2014 is when the Affordable Care Act got implemented, and behavioral health became a benefit. And under the behavioral health kind of umbrella, treatment is now available. So what we are seeing is traditional Medi-Cal managed care providers, medical providers, rushing to provide substance use disorder treatment, primarily through MAT, medication-assisted treatment, but also through behavioral health treatment, using modalities that we use in the substance use disorder treatment world, cognitive behavioral therapy, motivational interviewing. And I think because of our high rates of dual diagnosis, what's most exciting about the ACA is that psychiatry is now available. And so you can see there are multiple siloed funding streams, and counties are trying to, as well as providers are trying to cobble together a system of care that following these funding streams. So if we can go on to the next slide. So what has happened though what is happening right now is an incredibly siloed and trifurcated SUD system of care. 3 funding streams and a system of care that is really confusing and disjointed for not only participants but also for providers. And this is a system, even though it's the same Medicaid dollars, the same federal funding, because it's coming through these silos. It's it it There are barriers to true integration. These benefits are administered and billed for separately. So what's happened is recommendations, and everyone is talking about integration of behavioral health with SUD treatment and primary care, but the billing systems are make it very, very difficult. And what this results in is the lack of availability of treatment. I saw a statistic that 8% of us millions of Californians, we meet the DSM criteria for substance use disorder, but only 10% of those folks actually receive any treatment. And what this means for ethnic and LEP communities is really dismal. It means that the system that is very confusing and disjointed and almost impossible for ethnic-based CBOs to um, implement results in sparse and almost non-existent care in California. And so for the API community, I believe there aren't many of us. You can probably list us on one hand, um, less than 10, and probably less than 5 of us SUD providers across the state. And that really is abysmal considering how large the API population is here in California, the largest in the nation. Um, our API population is probably larger than some states altogether. And so the state of SUD treatment is in not so good shape. So with that said, if we can go on to the next slide. So with that said, um, even though the situation is pretty, it's in a lot of flux, it's siloed, it's trifurcated, it's confusing. But with that said, in the midst of all this change, there's some incredible opportunities to operationalize and really make available care. And so one of the routes that we have taken at KCS is to actually become a health center. And so I want to spend a little bit of time talking about why health centers are important in this process, community health centers, and how SUD treatment can either be nested in health centers or traditional SUD treatment providers can partner with health centers. So the health centers or federally qualified health centers, we really are pioneering integrated care in the entire health system here in California. Um, since the passage of ACA, Medicaid has expanded tremendously in California. In our county alone, we had 500,000 Medicaid enrollees here in Orange County that were newly enrolled in 2014. Um, and the way federally qualified health centers are designed, we can provide more than just primary care. So most health centers are expanding in providing mental health, some SUD treatment, medication assisted treatment, medical care, dental care, pharmacy, et cetera, et cetera, et cetera. The list goes on and on. And so health centers are emerging as one-stop centers for health care, which is very exciting. Health centers also, the wait, SUD treatment usually in my experience in the last 2 decades, has been filled with lots of doors that make it very difficult to get in. For example, if you are on Medicaid or not on Medicaid, if you are undocumented, not undocumented, you have to meet certain criteria, et cetera, et cetera, et cetera. Health centers in general take everyone who walks in their door, regardless of billing source, regardless of immigration status. Um, and what that does is it breaks down and it eliminates barriers to care. And usually health centers are designated in only high need areas. And so um, and so a lot of the traditional barriers to care are eliminated through the health center modality. Um, Health centers it's an exciting time to be a health center because there is funding down the pipeline. There was 94 million in 2016, 200 million in 2017, and that is just through HRSA, the federal government funding on substance use disorder expansion for health centers, and health centers are a good place to think about SUD treatment for ethnic communities because it's in general sustainable. Federally qualified health centers do medical billing. We call it a PPS rate in our world. and that allows us to sustain services. So, at the end of the day, it is about money and the ability to provide programs, and health centers provide a good uh, um, structure for that to happen. In addition, there's been some movement on the policy end. I believe last year or last year, drug Medi-Cal rules were loosened up for health center participation in the drug Medi-Cal program, and there has been a lot of support not only from the foundation community, but a lot of different funding sources to expand MAT and expand SUD treatment in the health center rubric. So why this is so it's as an ethnic service provider, it's important for us to smell the funding. Our role is to find where treatment is going to be supported through different siloed funding sources, and then operationalize it to our communities to provide that direct service at a very local level. And at KCS, what we've done is, even though we've participated in we are a drug Medi-Cal provider and we participate in different funding sources, most of our eggs right now are nested in the health center modality in operationalizing SUD services. And that is not only practical for us, but it's deliberate because with Asian populations, a lot of the stigma is reduced when you couch it in a health center. Primary care providers usually are the go-to folks for limited English-speaking populations to take care of a whole host of health needs. And so we found in the past, when we labeled ourselves as an SUD treatment provider, there was so much shame and stigma attached that it would be, it becomes much easier when it's couched in a integrated holistic health center format. And so health centers are good gateways for API communities to come in and receive SUD services. So it is an exciting time. There are a lot of good medications out there that are being used in conjunction with treatment medication, and the turn of DMC, or the movement with drug Medi-Cal to become more medically, uh, to have a medical necessity threshold and to use ASAM criteria, is had all the arrows for us here at KCS pointing towards um, providing SUD treatment in a health center format. So that is our story, and I will take questions afterwards.
Thank you so much, Ellen. And now we are going to have Raul, and he will be talking a little bit about how operationalizing the substance abuse treatment can look different in his community. And he actually operates a residential facility for substance use disorder treatment for Native Americans in Long Beach, California. And it brings just many, many years of experience and personal experience of overcoming gangs and substance abuse within his community. His experience has been in, counseling youth in South LA and Homeboy Industries before his tenure with American Indian Changing Spirits. And he's also established working relationships with tribal representatives for providing substance abuse treatment for natives living on reservations. He's actively involved in the Native American community in Los Angeles through collaboration with education, social services, ceremonies, and community social events, and as the current inmate spiritual advisor for the federal jails in Los Angeles, and a singer with a Changing Spirits drum, Raul leads fulfilling roles in the Native American and indigenous communities. So really lucky to have you here, Raul.
Thank you so much. Thanks for the introduction. I actually love to speak after Ellen because she always reminds me of what I should talk about. She's definitely one of my sheroes. Thank you for that introduction as well. But yeah, just a little bit about myself. I'm a Kumeyaay Native American from San Diego and Baja, California. on my mother's side, and on my father's side, I'm Huichol native from Mexico. Um, as far as American Indian, Alaskan Native continue to have some of the highest rates of health and social disparities and social economics. We also have the issues of racial issues that we continue to deal with. Mascots, costumes, sports teams. But I do want to say about some of the miracles that happen through our organization, American Indian Changing Spirit. We are a substance use disorder residential treatment center in Long Beach. We're the only residential treatment center for Native Americans in Southern California, and maybe 3 or 4 in the state. Really, the whole development of the program is very, very grassroots, very community based. There's this area back in the 60s and 70s in downtown Los Angeles called the Indian Alley, and there was a lot of Native Americans congregating there. They were on Skid Row, so a lot of drug abuse, prostitution, alcoholism. Some natives within the community got together. They were attending AA or other 12-step fellowships, and they kind of pulled their resources together to begin the first steps for American Indian Changing Spirits as a nonprofit. Like I mentioned, it's a Native program, but we don't discriminate against anyone who's looking for treatment. So you don't necessarily have to be Native American. Although we do have some MOUs and contracts with tribes in the state of California and out of the state. So as I mentioned, Native programs are scarce. We do have tribes contracted with Oklahoma, Montana, South Dakota, Arizona, New Mexico, and other states. So we're able to service natives coming from out of state as well. What we do is a very holistic approach to treatment. So by incorporating Native practices, Native ceremonies, Native cultural art. So again, it makes our program very unique. But then we also have the clinical component too. So when we offer evidence-based treatment such as motivational interviewing, cognitive behavioral therapy groups, healthy living skill groups. So we're able to mesh that in a nice, perfect kind of fit for everything. And then I think maybe you can move on to the next slide. I mentioned we are a 30-bed facility for males. We will be opening a female facility, 14-bed facility for females, and that should happen within the next month or so, or maybe even sooner than that. So we're looking forward to that. We're hoping to open that soon, and that's going to be a 14-bed female facility. Same program, same concept. And in the future, we'd like to do an outpatient treatment center as well. And then hopefully make our program, our women's program, Women with Children. Los Angeles County has actually the highest population of Native Americans. And one of the disparities that we suffer from here in LA County is the amount of Native children in foster care and the lack of Native American foster care homes. So again, we like to kind of tackle that issue with a program that allows for women with children. And so another thing is, we've been contracted with the state of California through Drug Medi-Cal and the Department of Healthcare Services and LA County Substance Abuse Prevention and Control since 1998. We have switched over to Drug Medi-Cal as of last year. So some of the things that we've been able to incorporate as far as like continually growing with, SUD treatment and how to stay, relevant or how to stay, afloat really for nonprofits, for smaller nonprofits like ours, is that we've been able to collaborate with behavioral health services. So Behavioral Health Services is a bigger kind of nonprofit with about 14 facilities that are residential treatment centers, outpatient sober living homes, et cetera. So we've been able to kind of collaborate with them, and that they've been able to support us through managing our smaller program. And that's a really good relationship that we've had since 2012 with them, maybe even earlier with them. Because what that's able to do is to allow us to continue to be a culturally competent and relevant program for Native Americans. So I don't know if I mentioned too much about some of the things that we do as far as like supporting traditions and culture, but we do have a sweat lodge on grounds that we utilize. We have Native American elders to come in and have counsel with our clients. We do have in the introduction they mentioned about our drum and singing. So we have a drum and singing, and we also have a cultural arts class as well. So beadwork, leatherwork, featherwork. And so the next slide would be good. That's a picture of our sweat lodge there. So that's a picture of our sweat lodge, as we mentioned earlier. Some of the stuff that we've been able to do also is kind of incorporate the ODS system with the LA County, so the organized delivery system. We continue to do full ASAMs, and so that our clients meet the level of care that's appropriate. We also have MAT services, so medically assisted treatment. What we like to do is kind of incorporate the community and any other issues that our clients may need. So as far as hooking them up and referring them to mental health through other Native American agencies. So we've been very fortunate to work within our community. So this one is community ownership and outreach. So I'm sorry, excuse me. So the community takes a strong ownership to our program. American Indian community, as I mentioned, is the largest in the country, but it's a very tight-knit community. So there's a lot of community involvement, and I think the next slide is good. So quality of care and best scope of practices, and I mentioned a little bit about the BHS management and affiliation. We've recently worked hard for credited this past year. I talked a little bit about the tribal MOUs and the ODS. So I guess our present situation is continually look at clinical, to kind of look at a lot of the issues that we've been dealing with as far as the Native population and dealing with intergenerational trauma, and how we can look at that clinically and how we can look at that holistically and how we can start addressing that. We really want to heal from the intergenerational trauma, and like I mentioned earlier, the health and social economic disparities that we focus on and that we're dealing with here. So we know that substance use is just kind of it's just a part of the problem with our population. So we really have to look at the trauma, intergenerational trauma, like I mentioned earlier, the racial issues. So as a whole, when we're tackling this, we'd like to do it as a whole, kind of wraparound services, and treat the person as a whole. So we're looking at all these different issues that may prevent long-term recovery, and that's what's been working for us. We're growing. We'll continue to grow. I'm meeting with a lot of tribes out of state now, and I'm doing a lot more traveling that way and letting them know that there is these programs out there. We're still here, and we're seeing any kind of resources that continue to support us and to help us grow. And yeah, I look forward to questions after this. Thank you.
Thank you so much, Raul. And now we are going to move on to Peggy. Peggy, are you on the line okay?
I am on the line.
Peggy Thomas, we're very lucky to have her, is the former Program Services Manager for On Track Program Resources, where for almost 20 years she worked throughout the state to coordinate training and consultant services for programs and organizations working with unserved, underserved populations and communities, including African Americans, youth, women, and women with children. She is semi-retired. I'm very jealous. Peggy remains a lead for On Track's mental health first aid instructor team, so she's still working, which trains persons serving high-risk populations on the signs and symptoms, characteristics of people experiencing mental health challenges, or provide assistance to those who may be in mental health crisis. So
Thank you so much, Peggy, for 2 decades of service, and take it away.
Well, thank you very much. It's sometimes it's almost like the things they remain the same no matter how much we try and we do some things different. But a lot of what we're seeing now with the opioid crisis is some of the things that we saw with the crack epidemic 20 years ago, and it's the similarities are just crazy. So as you mentioned, my organization, On Track, has over 20 years experience in statewide TA and training. We manage several contracts for the Department of Alcohol and Drug Programs, which is now under the Department of Healthcare Services. We had a couple of contracts with the Department of Public Health and several contracts with SAMHSA, the Federal Substance Abuse Mental Health Services Administration. So our focus has always been, our very first contract was the African American TA and Training Project, and our focus from there has always been about unserved or underserved communities, primarily communities of color. One of the things that the department, when it was the Department of Alcohol and Drug Programs, did was they had what they called special population contracts. So they had women with children, the LGBT community, the Youth TA and Training Project, again, the Faith Community TA and Training Project. So we did a lot of work with special populations. But what we realized was that the issues that people in the LGBT community are facing are the same issues that providers and folks serving women and women with children are facing. So those projects were really interchangeable. So what the department did was they folded all of the special population contracts into one huge contract called the Community Alliance for CLAS, which was when the federal government set out the standards for what they call cultural and linguistic appropriate services. And we managed that contract for its time, but I think that putting them all together was not really a good thing to do, because even though they were all special populations and they all met this criteria for needing cultural and linguistic appropriate services, I don't think that we were allowed to do as much for those special populations or specific populations as they were included in one huge contract. So next slide, please. So these are some pictures of some of the brochures that we've done, some of the regional trainings that we've done, the Community Alliance for CLAS. We've got the LGBT community. This was a project that we did serving young men of color. It was a regional training that focused on African American and Latino young men. This is women and children, with incarcerated women, the challenges that they have when they come out into the community. This was a training that we called Endangered Species. This is another youth training that, and actually it was a youth and an adult training. We just kind of switched the PowerPoint a little bit in terms of looking at the needs of folks when they, particularly folks of color, when they come out of the criminal justice system. We did a lot of work around women. We did some work around veterans, which now, back then, they weren't really doing a lot of services until our folks came back from the Gulf War and we started seeing a lot of PTSD. We saw a lot of suicides. So we did a lot of work around that as well. And some of the trainings that we did, tough cases, working effectively with ex-offenders, court-mandated, and treatment-resistant clients. Culturally responsive services for Latinas. One size does not fit all. Cultural competencies for working with dual diagnosed clients. The long way home, working effectively with criminal justice involved women. And each one of these contracts that we managed required us to do 3 regional trainings. So we were able to do North, Central, South. And over a 3-year contract period, we were able to really reach in and dig in and do provide a lot of services in addition to the trainings. We had accompanied about like 150, 180 technical assistance days that we could actually provide providers as well. Unfortunately, that has pretty much gone away as in the last few years, and they combined a lot of the projects together. And I'm not sure if that was like a really good idea, because the needs of women and women with children are totally different than the needs of young men or young men who are gang affiliated, even though their families may be their what are the intersections there. So next slide, please. So when the CLAS standards came out, they've been around for a really long time, but when the federal government actually made them mandate, it threw off the system a little bit, in that we knew we were doing these things, but we had to actually make them work or make them totally visible to the system in order to get reimbursed. So the study, the CLC study, had 8 different domains that are helpful to consider when folks are looking at implementing the CLAS standards. And we've actually even broken them down a little bit simpler, as most of our clients that we serve, that we work with, they're working with people. We need to be really down to earth about some of the things that they need to do, not speak, how do you want to say, higher level education language. We need to be able to reach folks where they're at and give them information that's going to be applicable in their daily lives. So the 8 domains that were really helpful in terms of looking at cultural and linguistic appropriate services was doing collaboration and outreach to cross-system partners. A lot of times, substance use and mental health, we didn't talk to each other. We were separate, we were siloed. A lot of the folks, especially in communities of color, we had folks that were involved in the mental health system, the AOD system, and the criminal justice system. How could we help this client if we didn't have linkages or information or contacts within our other system partners? Being able to be culturally competent. The CLAS standards are very clear on the things that we need to do to be culturally competent. And that was something that when they took the contracts and put them together, all of the special populations then had to go into one pot, if that kind of makes sense. Another thing was training and workforce development, the substance use, mental health field. A lot of folks that have been doing this work have been here 20, 25 years, and it's time for us to go. It's time for us to pass the torch. And so really looking at how do we train up the next generation of providers, and to really put it plainly, if young people are going to school for 4 years, they're not really trying to work for the wages and the hours and the things that you have to give up or put in to do work with community-based organizations. Looking at quality improvement and data, that was another thing that we struggled with in terms of trying to bring our community providers up to date. Again, the system of care governance, budgeting, planning, and management. A lot of folks that had been doing the work previously, I'm sure that some of you know, this program, it was founded by people who were addicts, former addicts, and they never had any real education. They just knew what worked. And so when the standards came in, we started having to do, you needed continuing education. You needed this, you needed that. So what it did was it kind of siloed a lot of the people that had been doing the work for a really long time and brought in people that didn't really want to hear about what we used to do. And so it created a little bit of a conflict a few years back for a couple of years, but now I think it's back on track. Budget planning and management, again, when we were put into a system of care, um, a lot of the substance use programs went away because they had to, in the management and the planning of their budget, they had to include some mental health, and their budgets didn't really support that. So, and really looking at policies and procedures. And then one thing, outreach and inclusion of ethnic and diverse populations, which was what OnTrack did, but really looking for outreach and recruitment of ethnically and culturally diverse young people into the field. Again, looking at what they had been paying and, substance use counselors, folks that have gone to school for 4 years, they really weren't going to do that. So some of us here on the panel have been a part of the movement for what seems like a lifetime now. And I think that rather than moving outside the system, we would do really good staying in and really trying to organize and make a difference and bring this younger new generation of providers into what the premise of this was in the very beginning. Next slide. The federal government came out with a set of what the CLAS standards. And these were the standards for cultural and linguistically appropriate services. They decided that if folks were getting federally funded dollars, then there needed to be a way that they could be evaluated, that their money could be spent, that their staffing had to have certain criteria, and some of these were guidelines or recommendations, but some of them were actually mandates. So we had to provide services in a client's preferred language. Now, that's kind of hard to do a lot of times. Not saying that it hadn't been done. We had a lot of great Latino serving organizations, a lot of Asian serving organizations that actually provided that service, but it wasn't mandated. And specifically around informing patients or clients their rights to those specific services. Again, the first three are basically around the mandates are around language, access, and materials and signage, that type of thing. Guidelines were strategic planning. A lot of folks that have been doing treatment, especially in lower income communities of color, we just knew that we had to do something. I like to use the story of an older lady in South Central LA. And if you go, everybody knows her. You know what I mean? You know Miss Jenkins. And, her house was placed basically on the track where the prostitutes would walk up and down, and she would sit on her porch and she would say, "Baby, you don't have to do that. Come on in here. Jesus loves you." Well, you can't really say that to folks these days, but she had a whole wall in her living room of young women that she had taken off of the boulevard, had got them into education, got them into school, helped them get their kids back. They were clean, they were drug-free, they were buying homes, they were, living life how they're supposed to, because she used a very grandmother, African American or Latina grandmother response to what was going on with them. So people like her, when these CLAS standards came out, she didn't have all of those things in line. She didn't have a social worker on staff or those kinds of things. So, in terms of looking at the mechanics of cultural competency, we have to make sure that we include some of those folks. The self-assessment, ensuring that the data is collected, all of those things are fairly new within the last 5 years. Next slide. And the necessary support. childcare, transportation, GED referrals, legal services. A lot of folks, when they first come into, they start thinking about getting clean or getting into recovery, they have so much legal baggage. Whether it be for men, a lot of men, it's back child support. For a lot of women, it's that their children are in the system and they have to jump through a lot of hoops, and they need help to do that. They need somebody to hold their hand to do that. We can't just say, okay, you get on this bus and you go down here and you get off that bus and then you have to tell them this when you get in there. That's not how that really works. A lot of times we would send them out and we wouldn't see them again because they would get disappointed and they would get overwhelmed, and then they would go back and use. So looking at gaps in service delivery and outreach and engagement of the community. A lot back in the early 2000s, we had a lot of outreach in terms of helping people. The faith community came on board, particularly African American Latino communities. When people get in trouble, they go to the church. And so we had a lot of faith communities that would open their doors for job fairs. They would do GED classes. They would have lawyers come and help people with their legal aid problems. And we don't see a lot of that too much anymore. And again, being very culturally specific, folks being able to really identify and touch base and be connected to the clients that they're working with and hoping to serve. Next slide. So in order for us to continue to be effective, as was mentioned, I've been around for over 20 years, over 20 years now. And in order for us to continue to be effective and really relevant in the communities that we serve, we need to continue to be network and be out there in the community. We need to be at all the city council meetings. We need to be at the health committee meetings. We need to sponsor health fairs. We need to have a Rolodex full of ancillary services. Oh, you need a lawyer and you have 2 children and one. Okay, let me look at my Rolodex and see who I can send you to. Tell them Miss Thomas sent you. You know, we need to have allies, and a lot of that has been siloed now. So I think that if we come back to that whole community model where we have African Americans and Latino and Asian and Native Americans all together, each of us serving our own populations, but doing it in a way that promotes healing across generations, across cultural lines. I think we need to get back to that. What was talked about earlier in the earlier presentation, you need to know who your congressional representatives are. You need to know who your county folks are. You need to have a relationship with your city council members. You need to have some of those people on speed dial. You need to look to see who's doing things in the community, be out there, be relational, and have a Rolodex full of ancillary support services that you know, and you can call them and say, I'm sending so-and-so, can you please help them? And let me know if I can do anything else once they get to you. So unfortunately, we still have a lot to do, but fortunately, we're still in the game, and folks still have a heart for serving their community.
Great. I was a little bit overwhelmed by your presentation. It was really inspiring. So thank you.
Well, it's really hard too, and I want to say this, that, it's really hard for young people who have gone to school, who have a lot of student loan debt, to go and work for a community-based organization. It's really hard to convince them that this work is worthy and inspiring, and they can do it, in the way the economics are set up. So.
Yeah.
It's just the fact that you guys are interested and will listen to the OGs. That's great.
So thank you, Peggy and Ellen and Raul, for all the things that you do every day in your roles and teaching us, how to move forward. So I know that, we've gone past time. We had to deal with tech issues, but 16 of you, you're all here. If you have questions, please unmute your line now and just ask away.
This is Angelo Williams from California Black Health Network. So I don't have any questions, but I just wanted to thank both the presenters, for really giving us great information and also inspiration in the work. I really appreciated what you said, Peggy, about the work. And also the cyclical nature of the work, that some of these things that we've seen in the past are here again, and that's really important because I think it just points to these systems that continue to work to produce these inequitable outcomes. So, we don't hear that every day, but we need to hear it, and we need to learn from, what's happened in the past. And so I really appreciate what you said. It's very helpful.
Thank you.
Thank you, Angelo. And can you share your organization, Angelo, so that everyone knows?
Sure. So I'm with the California Black Health Network. We're in California, obviously statewide. We're centered in Sacramento, but every year we go out and do workshops in 7 cities. We're trying to build a Black health agenda for African Americans and Californians of African descent, particularly the undocumented community. So that's why that piece around the cycle was important. That's some of the stuff we're up against, and it's good to hear information like that.
Angela, this is Peggy. You need to come see me because I'm based in Sacramento as well, over at the Sierra Health Foundation's NIC. So come see me.
Oh, perfect. Okay, I will. Absolutely.
So any other folks, you have any questions for Ellen and Raul?
Angelo again. I actually had one question for Ellen. I came in a little late, but I heard what you were saying around funding for health centers. Could you talk a little bit more about that? I just caught the tail end of it. I'm sorry, I didn't hear everything you said.
Yeah, so I did a presentation on how federally qualified health centers are poised to already receive funding and be sustainable in doing SUD services. So it behooves ethnic organizations either to become a health center, which is a very long and difficult journey, or to align themselves with health centers that believe in SUD work and believe in services to ethnic communities, and find ways to partner because SUD treatment is becoming much more ASAM-based, healthcare-based, integrated care-based. And so us traditional SUD providers who have been in the recovery world, but we're not necessarily medically oriented, I think we have to do a shift if we haven't done it already.
Mm-hmm.
It pays better. I mean, I will just be honest. It just pays better in the medical world than it does in the SUD world, and it's a lot more exciting to do the work when it pays a little better. Because I like Peggy, have been in this field doing SUD work for Asian Pacific Islanders, and I'm tired of SUD payment rates, SUD funding rates, and so it's been a lot of fun in the healthcare arena, in the health center world, and everything these days is about integrated care, medication-assisted treatment, where you need the medical professionals, and even treatment has gone to medical necessity with DMC. So it's to encourage ethnic providers, people who believe in getting these services out to communities of color, to really work with healthcare providers or become healthcare providers.
And so we have just a couple more minutes left to the webinar, and I'm going to let y'all go. But I think the last question, I have a question for Raul for, just your process in opening up a treatment center for such a small nonprofit organization. Is the process arduous? How long does it take? If you are maybe a nonprofit organization and you're serving the communities already, and you're thinking about, bringing on a treatment program into your organization. Is it
Thank
difficult?
you. Yeah.
How does it work?
Thank you so much. That's a great question. I think maybe doesn't get asked enough. And we actually went into this thinking that since we have our mail facility and our program established, and we are licensed through the state and contracted through the county, we actually didn't expect for it to take as long as it has been taking. So that's unfortunate, but I think that kind of going back even what Ellen mentioned earlier about how SUD treatment within the last 10, 15, 20 years, it's just been doors after doors. And it's unfortunate because we're doing the good work and we know the population is in need of it. And even again, talking about our specific population for Native Americans, we know that the need is there. We know the disparities are there. We know that one of the highest rates for teen suicides, drug abuse, and domestic violence per capita. So we would think that adding to the support network and residential treatment wouldn't have been so tedious and difficult with just adding to our existing license and contract, but fortunately it has been. But that does to never discourage, we need more programs. We need more cultural specific programs. We need more, like you mentioned, it allies, and I just am blown away with all the good information here.
Thank you, Raul. So thank you everyone for holding on to this webinar until 12:30. We're very grateful. Thank you, Raul, Ellen, and Peggy for joining us and inspiring us. And thank you so much for decades and decades of your work. We all learned so much from you. And I'm going to be sending a follow-up email with everyone's contact info so folks can be connected and get the information that they need. And yeah, I'm going to go ahead and close the webinar. Thank you everyone for joining us.